1. The broadcast is now starting. All attendees are in listen-only mode.
Well, hello, everyone. This is Güliz Barkan, the president-elect of the American Society of Cytopathology, reporting live from Loyola University, Chicago. For those listeners, participants listening to us on the webinar as well as the YouTube channel, from those of you from the US, happy National Cytotechnology Day. We're very happy, and for those of us, or those of you from listening from outside the country, this is a day in the US celebrated as the National Cytotechnology Day. And the reason why it's today is it happens to be Dr. Papanicolaou's birthday, at least on some of the records. It says that he was born on May 13 in 1881 in Kimi, Greece. So we might even have some Greek listeners along with us today. So today is Dr. Papanicolaou's birthday, and in about 1985, it was decidedly celebrated as the National Cytotechnology Day to celebrate Dr. Papanicolaou, as well as our cytotechnologists who do a lot, work with us and help our patients every day. So thank you all very much. With that introduction, that's the reason why we have 3 webinars this week. Yesterday was one, today's another one. And today's speaker, and Joanne, maybe you can switch on to Dr. Henry. Yep, there we go. Today's speaker is Dr. Michael Henry, who is a professor of laboratory medicine and pathology and the director of cytopathology in Mayo Clinic, Rochester, Minnesota. He is well known to the cytology world, a lot of accolades. He has been the past president of the American Society of Cytopathology. He's currently the secretary-treasurer of the society, and if I read through his CV, that would take up half of this conversation, so I wouldn't do that. But I also want to say he's an artist, and he takes beautiful pictures. I can't wait to see all these. Dr. Henry, it's all yours.
Thank you, Güliz. And I again want to echo Dr. Güliz's notice that today is Dr. Papanicolaou's birthday. I think it's appropriate that this is, I think, the only GYN talk that we're giving in this series of seminars. And so it's appropriate to give this on Dr. Papanicolaou's birthday. And this was not by prior planning or anything. Today, what I'm going to be talking about is high-risk HPV testing. I want to talk a little bit about the epidemiology of HPV, and then I want to spend some time talking about how you can use HPV testing in quality control, quality assurance practices in your cytology laboratory, because HPV testing gives us a really nice tool that we can use for quality purposes in a GYN cytology laboratory, which is really different than what we do in the rest of anatomic pathology or even in the rest of cytology. And it really gives us some data that we can use to try to make sure that we have the best lab possibly. So we'll start off today, and as Dr. Güliz mentioned, I love photography. I love birding photography. So the photos that you're going to see in here are going to be photos that I have taken. The last photo before this and this one were actually taken in Ecuador back when we could still travel to some of these countries. So talking a little bit about high-risk human papillomavirus infections, there is a very broad spectrum of clinical expression of human papillomavirus in humans. And it ranges all the way from a latent infection where you have absolutely no idea that there is an infection. There's no morphologic changes present with this virus. It's just present in the tissue. Common things that people see in HPV also include exophytic condylomas. These are typically seen in the epidermal areas, vulva, perianal, and in those areas, these are most often associated with low-risk HPV rather than high-risk HPV. Then you can get both low-grade and high-grade intraepithelial lesions, and these can be seen anywhere in the anal genital tract as well as in some other areas of the body as well. And then there are a number of areas where you can get invasive carcinomas in the anogenital tract, including cervix, vulva, anus, penis. And then, as I think we all recognize now, that there is a subset of head and neck cancers which are associated with high-risk HPV, as well as rarely in the esophagus, conjunctiva, even in the lung. So the natural history of human papillomaviruses ranges from a transient infection and then in some individuals, a persistent HPV infection. And this illustration shows this when you get a normal infection, and we'll talk about cervix here because the main area that we are most interested in cytology is in the cervix. And so you get an infection in the cervix that then becomes a HPV infected cervix, and in most cases, what you're going to see are mild cytologic abnormalities in these instances. And then a lot of times that is cleared and you go back to having a normal cervix, and then the HPV is either gone or it's present in a very, very low number where you don't have any morphologic changes. In some individuals, however, you will get a progression of these changes to a persistent HPV infection with a larger number of the viral particles. And then this can lead to more significant lesions, CIN2, CIN3, high-grade squamous intraepithelial lesions. And then in some individuals, that can then go on to invasive carcinomas. So as I showed you here, in a lot of individuals, they clear the incident HPV infection. And this occurs over a period of time. And if we look up here in the upper left of this graph, you'll see HPV 16, which is the one that's associated with most lesions in the cervix, or most high-grade lesions in the cervix. And we look here at women under the age of 30 and women over the age of 30. And you can see in both of these age groups, they tend to clear the virus somewhere between 40 and 60 months. Almost all individuals have cleared that HPV infection. And then it's either gone or it goes to an undetectable amount. And you can see this across the board with all HPV types. Now, as I mentioned, there are a number of HPV subtypes. The high-risk subtypes are these 14 subtypes here, or 16 subtypes here. 16, 18 are by far the most common. Then like what I'd like to call the odd 30s, 31, 33, 35, and then 39, for some reason, not 37, which kind of throws out my odd 30s signature there. But these are the ones that are most associated with high-grade lesions or the potential for invasive carcinoma. Low-risk subtypes of HPV are not associated with invasive carcinoma, except maybe very, very, very rarely. Now, if you look at the epidemiology of cervical carcinoma, in the United States, cervical carcinoma is actually a somewhat unusual carcinoma now, because we have a very good screening program. And so across most of the first world countries, cervical carcinoma is not the most common cause of death in women. But if you look at worldwide, it actually is a cause of female cancer deaths, approximately 10% worldwide. And so if you have a good screening program, you can decrease this number significantly, but there is a lot of variation across the geographical regions. And this chart here shows this, this incidence, and this is true now as it was in 2008. And you can see that the equatorial type countries, or the countries that do not have as great of an economic growth, are the ones where you tend to see the most numbers of cervical cancer, and most of this is due to lack of screening. And this is, again, HPV DNA prevalence in these worldwide regions, and you can see in the areas where we had the greatest number of cancer deaths, these are also the areas where we have typically the highest amount of HPV as well. Now, this slide again shows prevalence of the 8 most common HPV types in invasive cervical carcinomas. And as I mentioned earlier, about between 65 and 75% or so, depending on where you are in the world, of invasive carcinomas are going to be associated with either HPV 16 or HPV 18. And by far the most common viral type that you see in invasive carcinomas, you see this in over 50% of invasive carcinomas worldwide, is going to be HPV 16. So the vaccines that are out there now that target HPV 16, HPV 18, and then some of the other virotypes, I think we're going to start seeing as we go along, we're going to see a real change in this particular data set, and you're going to see fewer cancers caused by HPV 16 and 18, and they're going to potentially see more cancers that are going to be caused by some of these other virotypes. But I do want to kind of point out that there is some variation worldwide in virotypes. And if you look in Africa, HPV 33 and HPV 45 are a little more prevalent than they are in some other areas. In Asia, HPV 52 and 58 can be seen in cervical cancers a little more commonly. And so there is some variation. North America I find interesting because by far the most common virotype seen in invasive cancers is going to be 16 and 18, with over 3/4 of the cases having one of those two virotypes. So how does HPV cause these lesions? So HPV integration into the human genome is how high-grade lesions or invasive carcinomas are going to come about. And this is not a part of the normal viral life cycle, because integrating the HPV into the human genome means that it's not going to replicate, and it's not going to pass itself on from one person to another. It's not going to be infectious if it's integrated. But it does occur, and it occurs at random sites in the human genome. And when it does integrate into the human genome, what you tend to see is a loss of about 50% of the HPV DNA, which includes the E2 region, which is a suppressor of the E6 and E7 areas in the HPV DNA. And what you see is integration of the virus into the human genome, even in low-grade lesions, but more commonly seen in the high-grade lesions. So the mechanism then for transformation from a normal cell to a pre-neoplastic or neoplastic cell, again, requires that integration of the viral genome into the host genome. And the HPV genes E6 and E7 are the genes that are thought to cause the transformation. These are always conserved in the human genome, again, with that loss of E2. And E6 inhibits P53 in the human genome. And this can allow cells to enter S phase without a normal DNA repair function. E7 binds the retinoblastoma tumor suppressor gene product and again allows cells to proceed uninhibited through S phase. And what this can do is essentially immortalize these particular cells. And again, I am not a molecular pathologist, and so we're kind of reaching the edge of what I know about the molecular aspects behind HPV integration. But I find these, a couple of diagrams actually a little bit interesting. So E6 expression and genetic instability, and this is a very simplistic way of looking at this, but if you have a mutagen, and HPV in and of itself is actually not a mutagen. It's not causing invasive carcinoma. What you have to have is a mutagen that causes DNA damage. And in an HPV infected cell, what you don't have is you don't have the increased P53 and increased DNA repair enzymes that allow the cells to repair themselves. Instead, what you get is DNA damage. You don't get decreased cell cycling, you don't get the DNA repair, and because of that, you can then head on into an invasive type situation. Also, one of the things that we need to kind of know about here is that E7, because it leads to increased expression of P16, and P16 is one of the surrogate markers that we can use when we are typically looking at tissue studies, but there are some advances now where we may be able to use P16 staining in cervical cytology, but that's a topic that I'm not going to be covering today. But what happens here is that the retinoblastoma gene product it blocks the promoter of the P16 gene, and when E7 blocks the retinoblastoma gene product, we lose that suppression and we get increased amounts of P16. And so that's why P16 is a surrogate marker for high-risk HPV integration into the human genome. So as I mentioned earlier, there are a fairly large numbers of cancers that are associated with human papillomavirus. The most common site of HPV-associated carcinomas are going to be in the female cervix, and worldwide there are over 500,000 cervical cancers due to HPV. Again, in the United States, we don't see all that many cervical cancers, again, because we have a good screening program. We are now, though, seeing or we're recognizing more types of HPV-associated carcinomas. So anal carcinomas are something that we're seeing more often, and we certainly see anal cytology now. Those specimens come through cytology, and we can do HPV testing in those lesions as well, similar to what we do in the cervix. There are vulvar and penile cancers that are associated with human papillomavirus, certainly at a far lower level than where we see in the cervix. And then the oropharyngeal lesions, and this is an area that's become well recognized over the last several years, again, due to this high-risk HPV infection. So moving on to HPV DNA testing, there are a number of DNA tests now that are out there that are FDA approved, and those are the only ones that I really want to talk about today. FDA has approved 4 different HPV tests for ThinPrep, and there is one FDA approved test for SurePath. Hybrid Capture 2, Cervista, Cobas, Aptima. And Hybrid Capture 2 was the very first one that started over 20 years ago, now almost 25 years ago in 1995. And just more recently in 2016, the FDA approved the Cobas test for SurePath testing, although some of these other tests certainly can be used with SurePath as well, as long as you follow their instructions. I'm not going to really be talking about in situ hybridization or PCR tests that can be used, because these are generally going to be used in research type situations, not in the clinical laboratory. So of these tests, Hybrid Capture 2 has a separate high risk and low risk probe mixture. In cytology, we are really going to only be concerned with high risk HPV testing. Invader technology has separate tests for high risk mixture as well as HPV 16 and 18. The Cobas, and this can be done on two different platforms now, the 6800 and 8800 or 80 were just more recently approved, and they do concurrent testing for HPV 16 and 18 as well as 12 other high-risk HPVs. And then Aptima does an E6, E7 messenger RNA from the 14 high-risk virotypes. So Hybrid Capture 2 is all four of these are commercially readily available. As I mentioned, they're all FDA approved, so they all essentially are equivalent. But I'm going to show you that there are some differences between these tests. And so whichever test you're using in your laboratory, you should be aware of some of these potential limitations. So Hybrid Capture 2 is the one that's been out the longest, very good test. It's high-risk probe mixture, looks at 13 different virotypes. Sensitivity is about 5,000 copies of HPV, and there may be some cross-reactivity with low-risk HPV DNA. Now, all of these tests are not run at a super high sensitivity. And the reason for that is that you want to keep your sensitivity high, but you also want to keep the specificity reasonably high with these clinical tests. And so you don't want a test that is so sensitive that it's going to pick up one or two viral particles, because those are probably not necessarily clinically significant. So all of these tests have a sensitivity level that runs, not down to that single HPV particle. So the Invader technology, again, commercially available, high-risk probe type with 14 different high-risk types. They added in HPV 66, which the Hybrid Capture 2 does not have. This is an isothermal DNA amplification with fluorescence. It does not cross-react with the low-risk HPV DNA, and unlike the Hybrid Capture 2, it also has an internal control to say whether or not you have DNA sufficiency or not. The Cobas test, again, FDA approved. One of the differences here is that the Cobas test gives you individual results for HPV 16 and 18, and this can be useful in the latest guideline for directing treatment or follow-up. And then it has pooled results for 12 other HPV virotypes. This is, again, a qualitative PCR test, and it looks for the L1 region of the HPV genome, and it also has an internal control. The Aptima test, commercially available for pooled results for the 14 different virotypes. The interesting thing about this one is that this one detects the E6, E7 messenger RNA. And because of that, that it may be a little more specific test for viral integration into the cell rather than just a test for the virus itself. There are a number of studies out there that compare the different tests from one to another. This was a study, a very large study that looked at Cervista versus hybrid capture 2 with biopsy-confirmed CIN2+. Both of the tests, as you see here, have a reasonably high sensitivity and a reasonably high specificity, and that's what you want with this type of test. And even though there is some variation here between the sensitivity and the specificity, these are clinically equivalent tests if you look at the area under the ROC curve. We did a comparison of HPV, 3 of the HPV tests. We got sensitivity and specificity by for CIN2+ using an adjudicated test set. So these were adjudicated P16 proven CIN2+ biopsies. And we looked at the Cobas, the Aptima, and the hybrid capture 2. And again, you can see that the sensitivity for all of these is good. All of them were above 90%. The hybrid capture 2 is certainly the most sensitive test that's out there, but it tends to have a little lower specificity. And so again, when you look at that area under the ROC curve, these are all clinically equivalent tests. One of the things that I find very interesting, though, is if you do a Venn diagram of these HPV positive specimens, what you find is that we had 451 positive cases. Only 324 of those tested positive with all 3 of the tests. And there were larger numbers of samples that tested only positive with hybrid capture 2. The Roche Cobas, though, did have a subset of cases that only tested positive with the Cobas test. And the Aptima test also had a small subset that only tested positive with that. And so there is a variation between the tests. And so again, you have to know which test you're using in your laboratory, and you have to know the characteristics of that particular test. And so they all work a little bit differently one from another, even though these are all clinically equivalent tests. All right, so that's a little bit about the testing of HPV and the epidemiology of human papilloma virus. And now what I want to talk about is some of the uses of HPV DNA testing. You can use DNA testing in the management of ASCUS. You can use it for primary screening, secondary follow-up, clinically after an abnormal TAP, even using this type of testing post-treatment. But I'm going to now spend the rest of our time here today talking about quality management. I am going to put in a shameless plug here, though, and say that I'm going to be giving a e-conference coming up from the ASC. And in that one, I'm going to be talking about some of the other clinical uses of HPV, including the recommendations from the latest guidelines from the ASC-CT. But that's going to be coming up later this year, I believe, in June. But we're going to spend the rest of the time today talking about quality management using human papilloma virus testing in your cytology laboratory. All right. So how do you use HPV testing in your cytology laboratory? I highly recommend that if you are doing cervical cytology in your laboratory, that you find some way that if you're not doing the HPV testing in your own facility, that you find some way of getting the HPV results from your cervical cytology, because these HPV rates and incidence should be a part of your quality management in your cytology lab. That data can be derived either from HPV reflex testing, and HPV reflex testing is not it's not just done on ASC-US cases, but it's also done, can be done on LSIL in postmenopausal women. Some laboratories will do HPV reflex testing in NIL cytology that does not have an endocervical component, because there are some ASC-CP guidelines that can use that particular data, and some laboratories will do reflex testing on their ASC-H cases as well. And you should also try to get that data from your co-test specimens. And HPV co-testing with cytology is probably the most common mechanism for testing for cervical cancer screening in women over the age of 30 now, at least in the United States. If HPV testing is not done in your laboratory, you should really make an effort to try to get that information so you can use it as part of your quality management. So what is the role of HPV testing in your QA lab? Again, you should monitor your HPV rates from your reflex ASC-US testing. You should monitor that for both your individual pathologist as well as your cytotechnologist as well as laboratory as a whole. HPV rates for co-tests over the age of 30 can also be monitored by diagnosis, and this again can be monitored both in individual pathologists, cytotechnologists, as well as your laboratory as a whole. And all of these ways, there are a number of ways, and I'll show you as we go along here that this can be utilized. There are, if you're going to be looking at this, you need to have some sort of standard to compare your laboratory to, and there is a lot of good data that has come out of the College of American Pathologists questionnaires dating back to 2003 questionnaire, 2006, and this is data from the 2003-2006 questionnaires that was published in archives in 2008. And this data, while it's old, I'm going to show you is actually still good data. And it shows you the HPV percentages here in ASC-US reflex cases. And if you look here, you can see that the majority of laboratories had somewhere between 10 and 60% of their cases were ASC-US positive in both of these years. So this can give you an idea of where your laboratory sits. I think it's a little more useful, though, if you look at the percentiles of laboratories compared to the percent of HPV positivity in your ASC-US cases. And this is data from the 2006 questionnaire, where we got a little more detailed into collecting some of this data. So 157 laboratories across the country were able to give the CAP data on HPV positivity in their ASC-US cases. And you can see here that there is a fairly broad range of positivity in this, but I think you can see here that, if you want your laboratory to, be somewhere between the 25th and 75th percentile, then you would want your HPV positivity rate to be somewhere between 26 and 48% in there. And the average here at the 50th percentile was 36.6%. For those labs who were testing it for ASC-H, you can see that this number is slightly higher. and that very few laboratories had a 0% HPV positivity for their ASC-H cases. And there is also some data here on NIL cases, and this is from the HPV co-test population. And you can again see, well, there is a variation here. The 50th percentile was about 4%. HPV percentiles, we got more recent data here from a 2013 questionnaire to try to see if there was any change in these percentiles. And what you'll see here is that there was really minimal change in these percentiles here of ASCUS, ASC-H, and NIL. Again, there is variation varying from the 10th percentile where you're down around 12% positive to the 90th percentile where they're at about 55% positive for your ASCUS cases. But again, the 50th percentile was right around 40% of the ASCUS cases testing positive for HPV. This questionnaire also asked a few other questions, and this one I find interesting. And this, again, is something that you need to do in your own particular laboratory, and you need to look at what population are you serving in your lab. Are you serving a predominantly older population, or you are serving, say if you're in a college type setting and you're serving a predominantly younger population, there actually is significant difference between ASCUS in women that are over 30 and women that are under 30. And so you can see here that the 50th percentile here, if you're a younger individual, you're more likely to have high-risk HPV positivity than if you are a older woman over the age of 30, where again, so there is variation here in depending on the age of the population that you are going to be testing. This questionnaire also got some data, reflex testing for HPV in LSIL. This was something that came about because the guidelines that came out in 2012 suggested that you could do HPV testing in postmenopausal women for LSIL. And you can see here that only 20% of women who are postmenopausal with LSIL have high-risk HPV. The median number here was 20%. And that can be useful in treatment or follow-up of these particular individuals. But it can again be used in quality in your laboratory. And you can compare your lab to these numbers that are consensus numbers that the CAP put together. If you compare 2006 versus 2013, what I find interesting here is that there is minimal difference between the HPV percentages that the CAP got in 2006 versus the questionnaire from 2013. And so I think this means that there's not been a shift, certainly in the country, either with the new tests that have come out or population-wise. And certainly in 2006, almost all of these were hybrid capture 2. 2013, now there's going to be more variation in the type of test that's being used in the laboratories. Again, 2006 versus 2013, I'm just going to look at the 50th percentile here for labs. And again, ASCUS, it was almost equivalent. ASC-H, again, almost equivalent. And for NIL, there was a slight increase in from 2006 to 2013. The supposition from the paper where this was published is that this may be due to a population change, that the co-testing may be being used in slightly younger individuals than it was in 2006. But again, these numbers are fairly steady across this time period. So HPV positive rates and ASCUS, there was some Q-probe data from the early 2000s that suggested that a HPV positive rate of about 44% would be an appropriate quality metric in your laboratory if you were looking at comparing your HPV percentages to a quality metric. But I think you do need to recognize here that your own individual laboratory can vary. And as I showed you earlier, one of the big confounding elements here is going to be the age of the population in your particular testing situation. Other studies, that median rate varies. I think the CAP data is probably the best out there because it looks at a large number of laboratories across the country. Again, recent meta-analysis reports show that pooled estimate of high-risk HPV in women with low grade, and this is from the co-test population, is about 76%. And this is compared to that 20% of women who are postmenopausal. So again, you can see a big variation here depending on the age of the individual. You're going to see a lot more high-risk HPV in LSIL in younger women than you do in postmenopausal women. All right. So this is some data that we got in our laboratory. And so now what I'm going to be showing you are some examples of how to use HPV testing in a quality management type program. This is data that we have published, and it's from our co-test population for the most part. And it shows the HPV genotyping result using the Cobas test where you get 16 and 18 as well as other. And in a colored sort of way, it shows you the percentages of positivity. So in this particular data set, the percent positive rate for ASCOs was running right around 35%, up to a little over 90% with HSIL. And I'll talk about that here in just a minute, but I want to talk about ASCUS and ASC-H. And one of the things that you can do here is if you have this particular data, you can see that you can look at HPV other here, which is the green, or in the reds and the purples, these are various combinations of HPV 16 and HPV 18 positive. And you can see that in ASCUS, this is going to be much lower. In ASC-H, it's going to be much higher. And so you can compare these two populations to see, you should have a higher rate of HPV 16 and 18 in your ASC-H population than you do in your ASCUS population. And then if you can get almost the same look as you compare LSIL to HSIL. Again, the most common high-risk HPV type that you're going to see in LSIL is going to be HPV other. And in high-grade lesions, over 50% of those are going to be some combination of HPV 16 and 18 positive with or without HPV other. And again, this is something that you can compare in your laboratory to see if, and you can compare this to published data. I do want to point out here that even though we consider high-risk HPV to almost be necessary for a high-grade squamous intraepithelial lesion, what we found and what other people have also found is that your high-risk HPV positivity rate for your HSILs in your cytology laboratory is not going to be 100%. It should be somewhere over 90%, but it's not going to be 100%. And those negative HPV cases that are cytologically HSIL, we took a look at that stat, and we found that about 2/3 of those on biopsy were P16 proven high-grade lesions. And then about a third of them or so were probably false negative cytologies. Again, don't expect to have 100% positive rate for high-risk HPV in your HSIL cases, because you're not going to get there. And if you do, you're probably undercalling your high-grade lesions on cytology. So I'm going to show you some examples of the process that we've used at varying times in our laboratory looking at this. We look at all of our pathologist reviewed cases, and we have a fairly long-term data set that we can compare our all-time totals here in our co-test population. And then we can look at subsets of this to compare the one to the other to see if there's any significant variation over time. And we also look at our total HPV positive rate, again, to see if there's any significant variation in that over time. And if there is, we would want to take a closer dive to look at what might be the cause for that. We look at our HPV co-testing cases that test positive for HPV. And again, we look at that over time, and we look for variations in this particular percentage. And we're finding right now that we're running right around 11-ish% of our co-testing cases that test HPV positive. And this is all diagnoses. This is not just NIL. We also look at our co-test cases that are cytologically negative to see if there is variation, again, over time. And these are the upper limits. So we want to keep our testing within these upper limits here. And you can see again that we're running right around 7% or so of our HPV NIL or our cytology NIL cases test positive for HPV. And again, this is something that you can follow over time. ASC-US to HPV reflex is a very important statistic. As I showed you earlier, there's good data out there that you can compare your laboratory to. Again, we follow it over time. We look at the upper and lower limits, and we want to stay in between this. And if we get a quarter where it jumps out, we would want to look at why it does this. And again, we tend to run somewhere between 30 and 40-ish% in our that positivity, but it does vary a little bit over time, and that's why you don't want just to look at one particular number. You want to look at a range of numbers, and you want to follow it in your lab. We look at our individual pathologists. We give them quarterly statistics of their HPV positive in their ASC-US cases, along with their ASC-US to SIL ratios. Our goal for our ASC-US to SIL rate in our laboratory is less than 2. So we can look at that particular number right here. You can see what our various pathologists do with that. This is all data that is it's given to each individual pathologist, but we don't know who these are. So the names are hidden from this. But you can compare yourself because you know what your ID is, so you can compare yourself to the rest of the lab as a whole or as individuals. And what we like to see is there is going to be variation between the pathologists, or if you do this with your cytotechnologist, there's going to be variation. But you want to try to keep it, in that reasonable range. We look at our HPV results by diagnosis, by pathologist, and by cytotechnologist. These are our overall numbers. And then we give this information to each pathologist as well, so they can compare themselves to the overall laboratory numbers. And again, this is a way to see if we are getting out of range. As I mentioned, we give all of this data to our individual pathologists. They see what their diagnosis rates are for the different diagnoses, as well as their ASC-to-SIL ratios for each particular individual. Our goal is less than 2. We have some pathologists that always are going to be a little bit higher than that, some that are a little lower. We don't want, but essentially we don't want them to be way out of range. Now I'm going to show you something. This is from a while ago. This is an individual pathologist ASC-to-SIL ratio with HPV positive, and this is another chart that we provide. And I want to take a look at one particular pathologist here with an ASC-to-SIL ratio of this quarter that was outside of the range that we were looking at. And so we wanted to say, okay, is there some reason that this particular pathologist might have fallen out of range for this particular quarter? And one of the reasons that this could happen, by the way, is if their numbers are really, really low in a particular quarter, then their statistics could be really skewed because of that number. So that's one of the things that you want to look at, is you want to say, okay, is this particular individual not looking at very, very many cases? Because if they've only looked at 4 cases like this pathologist, these numbers really don't mean very much. So this particular pathologist had an ASC-to-SIL ratio of 4.2, where the lab average was 1.6. So I want you all to kind of think about this a little bit and say, is this particular pathologist overcalling reactive to ASCUS? Are they undercalling LSIL to ASCUS? Or are they both undercalling LSIL and overcalling reactive? Or are they doing any of the above? And I'll tell you right now is that if you don't know anything else about this particular individual, it could be any of the above. So this person could be overcalling reactive to ASCUS. They could be undercalling LSIL to ASCUS. Any of these would give you an ASCUS-to-SIL ratio that's way above the lab average. So it's not particularly helpful. However, if you know what their HPV rate in their ASCUS cases is, and in this particular individual, the ASCUS-to-SIL ratio is 4.2, their percent of positive HPV was 40%, and the lab average was 37%. So it's about normal. So now I'm going to ask you the same questions. Are they overcalling, undercalling, or both undercalling LSIL and overcalling reactive? And with this additional bit of information, you're going to actually be able to say that this particular individual with an increased ASCUS-to-SIL ratio, normal HPV reflex percentages has to be both overcalling NIL to ASCUS and undercalling SIL to ASCUS. So they are putting more cases into ASCUS, both from NIL and from LSIL. And this chart is something that Dr. Ed Cobas published. I think this is one of the most useful quality charts that's been published for GYN cytology in 2008. And what it does is it looks at both the ASCUS-to-SIL rate as well as the percent of HPV positivity for these ASCUS cases. And it lets you know for each of these exactly what that particular cytotechnologist or pathologist is doing when they're making these diagnoses. So if you have an increased ASCUS-to-SIL rate and you have an increased HPV positive rate, they have to be undercalling SIL. If they have a decreased HPV rate, say that it's 20% versus a laboratory rate of 40%, they have to be putting cases that are NIL up into ASCUS. And so you can go down the road here looking at whether the ASCUS-to-SIL rate is increased, normal, or decreased.
those of us who are laboratory directors, these were all very good pointers for us to use on our daily practices, how to do QC and when to do it, and that sort of information. This was very, very good. Thank you. Now, there are a couple of questions, so I'll kind of read them out to you as they come. So the first question is about doing HPV testing in LSIL cases in the postmenopausal woman. And the question is, what is the advantage of doing this? I think this was the ASC-CP guidelines from 2012. Correct me if I'm wrong. And
That's
they're asking,
correct.
Okay,
Yeah.
and they're asking, what's the advantage of doing this?
So this is something, when we first started doing HPV testing, and the big ALTS trial determined that HPV testing for LSIL was not clinically useful. That has evolved over time, and the 2012 ASC-CP guidelines said that for postmenopausal women, knowing whether or not it was a high-risk HPV type causing their LSIL did have clinical significance, and so that if they were high-risk HPV negative with LSIL, that they could be followed and did not necessarily need a colposcopic examination. So they are at low risk for developing a high-grade lesion or invasive carcinoma. So it's useful in follow-up of these particular individuals. And as I showed you, it's interesting because in the postmenopausal age group, that high-risk positive rate is actually significantly lower than it is in the premenopausal age group.
How about the new ASC-CP guidelines? Do they still recommend this in the new guidelines?
That's not really changed in the new guidelines. So the new guidelines are more risk-based. And if you look at those, that's still something that I believe is still useful, because again, what it does is it implies lower risk for those particular individuals.
Another question is for the HPV clearance studies. Question is, how was clearance measured? Is it HPV testing or cytology? Could sampling issues be a concern?
Now, I'm not sure exactly what testing was used for those. Again, the clinical tests that we use are not the most sensitive PCR tests that you might use in a research type situation. And I don't remember exactly what testing was used in that particular study. But what it does is it means that what happens is that the viral load drops below the threshold of the test. And whether it is completely cleared or whether it just drops down to be below the threshold of the test probably varies from individual to individual, because we know that women can harbor HPV over a long period of time at a threshold that's not going to test positive, and that they may reactivate that infection later on in their life, and then the virus can replicate and become detectable again. So clearance in this particular case just means falling below the threshold of the test that was being used, and it was it was not cytology.
Gotcha. Yeah. Another question is about, let's see, 10 years ago, we expected fewer PAPs by now and more HPV testing as primary screening. This hasn't quite happened. What are your thoughts?
Okay, so
it hasn't happened for the ASCO.
Yeah, this one again, I'm going to shamelessly say that I'm going to delve more deeply into this in the e-conference talk. But the bottom line is that at least in the United States, because of the testing, the way that we do cervical cancer screening in the United States, the clinicians here have, I think, feel more comfortable with doing HPV co-testing with cytology rather than doing HPV screening by itself. And so, at least in the United States, because we don't have a nationalized program where the test is determined by a government group, we're just not really seeing primary HPV screening as the primary cervical cancer screening in the U.S.
Yeah, yes, agreed. Another question is about the ASC-SIL ratio, and this is actually an important thing for the the residents and fellows listening to us know. The question is, why is it important? And if a lab's pap smears are very low, can the ASC-SIL ratio be disregarded?
So, yeah, that's a great question, actually, and all of these statistics require a certain, threshold number. And if you're in a laboratory that does, number one, I don't think that if you're a cytology lab and you're doing very, very, very few cervical cancers, PAPs, you're screening, I'm not sure that your lab should be actually doing those, number one. I think there's a certain minimum that you should do. That's just my own personal opinion. And what you need to do, though, is and this is something that we were doing in our laboratory. What we found is if you do your statistics, say, and at a monthly rate, the numbers are probably your numbers are going to jump around a lot because you just don't have enough cases to look at, especially for individual pathologists. And so what we started doing actually quarterly is actually doing rolling numbers. So we would take maybe 6 months worth of data, and every quarter you drop out the first quarter's worth and you add in the next quarter's worth. And so those rolling numbers give you a higher number, and it levels out the variation that you might see because of low numbers of cases. And so every laboratory is going to have to look at that. If you're a very large commercial laboratory, and your pathologists are just looking at cervical cytology cases, you're going to be able to look at much shorter periods of time and look for variations. But if you're in a laboratory where your numbers are much lower, what you're going to have to do is accumulate data over a longer period of time in order for them to be statistically relevant.
Mm-hmm. This is actually a very good point. One size doesn't fit all, so every laboratory has to look at their own numbers.
Absolutely, and you also and you have to look at your population because if you're dealing with a young college population, your HPV rates are going to be different than if you're dealing with a population that might be 50 years or older.
Mm-hmm. And similarly, if you have, say, pathologists on at short intervals, maybe their numbers are lower, but some others are at sort of a higher rate, perhaps instead of doing it quarterly, maybe doing it semi-annually, or QCs might work better, right?
Correct. Absolutely. If your pathologist only looks at 5 cases, the numbers that you get are meaningless.
Mm-hmm. Yes. A couple of other questions are coming. So one question is, in your laboratory, are negative cytology cases that are HPV positive automatically get put in for QC?
Oh, that is a fabulous question. So we do that, but it's going to depend a little bit on your LIS system. And our LIS system, at one point, we were able to do our screening before we knew what the HPV results were. And then we would get the HPV results, and if they were positive, we would send those cases for quality review. And we found that very useful as a quality measure in the laboratory, just as good as the 5-year look back for finding whether or not we had an issue with screening. Currently, though, our system is set up so the HPV results are put in automatically when they're done, and they tend to be done before the cytology is screened. So now we know what the results are when it's being screened. But again, if it's screened negative, we do send it for quality review, but we don't find it quite as useful now. But yes, I do think. But what you have to recognize is that you should not be looking and saying, okay, it's HPV positive, there has to be an abnormality, because that you really have to watch your data and make sure that you're not over-calling cases just because the HPV is positive.
Yes, that reminds me of an Anne Moriarty study, the Lake Tahoe study.
Yep.
Yeah. Yeah. So what is your LIS system, if you don't mind me asking?
Right now, we were on an older Cobas system, and now we're on SoftPath.
Okay. And I'm assuming that your HPV and your cervical cytology is in one report, or is it two separate reports? How does it go?
And that's another great question. I feel, that if at all possible, you should put out your cytology with the HPV results, because that way the clinician has both of those things in their hands at the same time without having to look at two different places. We're lucky here because we can do that. We run our HPV in our clinical virology laboratory, but it automatically drops into our cytology report because our LIS system can do that. But in some places you can't do that. You report the cytology, you send out the HPV testing, and it's done elsewhere.
Right.
But if you can put it in the report, I think it's important to do that.
Yeah, I totally agree. Yeah, with us, we actually send it out, and unfortunately, it can't come out on one report, and I wish it was. It makes it so much easier to go to one place and find out everything there. Another question from one of our participants. Do you have any experience with the BD on Clarity HPV test?
I do not have any experience with that at this point. No.
Okay. Another question is, if cytologists can see the HPV result at the time of sign out, how do these numbers help for QA/QC from a different participant?
We've looked at that in our laboratory, and what we found is that we've not seen a significant difference from our historical numbers to current, but it is something that I would look at to make sure that your texts are not being biased by the HPV results. So we did do that, and we didn't find significant bias.
I see. Okay. There's a couple of other questions. So you showed us your data, like you do your quarterly QA with ASCUS and HPV, and you give it out to all your pathologists. And once in a while, that in the example you showed, you could have someone with a very high ASC-SIL ratio, or the off ASCUS HPV testing ratio. What do you do for correction, or does it automatically correct and you don't have to do anything?
I've talked to Dr. Cobas about this as well. It's a great question. What you tend to see is an automatic correction in the pathologist. So if it was something that was continuing and it was a definite outlier, then it would be something that I, as a director of the laboratory, would talk to that particular individual about. But what we have found, and what Dr. Cobas said that he's tended to notice as well, is that pathologists auto-correct. They see where they're at, and they see where the rest of the laboratory is at. And if you give them the information and you tell them what it means, then they're never. Pathologists always vary, and we know that, and cytotechnologists as well. And there are pathologists that are going to be, more liberal in what they call things, or less. They're going to be more nervous about calling something nil. So there always is going to be some variation in your pathologist, but what you're looking for are significant outliers, and those do tend to autocorrect.
Mm-hmm. Yeah, one of the things I find out that if the pathologist gets something as atypical, not only in cervical cytology, in other areas too, it's kind of difficult to overturn an atypia just psychologically. As pathologists, you end up agreeing to it. So if you actually are able to reduce the atypia levels of our cytotechnologists, that kind of transfers onto the pathologist, and then you have a reduced atypia rate overall.
That's true, and that's important as well, is because I think it's if you have cytotechnologists that are tending to really significantly overcall, that's going to flow through to the pathologist as well. And this is why you have to look at your laboratory in total when you're doing this.
Right, that really helps.
Yeah.
Okay. One last question for you. You had a very nice graph on HPV genotyping, a study from 2014 and 15, and you showed it was toward the end of the PowerPoint, and I think there was something about most of these were HPV 16 or 18, but somehow the question is this squamous cell carcinoma had a lower HPV genotype rate. And I was trying to wrap my brain around that. Yeah, that one there.
Can you see it? Okay.
Yeah,
so,
yes.
Okay, this is because there were only 2 cases.
Oh, I see. Okay.
Right. So the value here is 1 because there was 1 case, and there was 1 case that was HPV positive and 1 case that was HPV negative. And this, so it again goes to show you that if you don't have numbers, you're not going to be. It's not going to make any sense.
Exactly.
But I think the data actually does show that in invasive carcinomas, the HPV detection can sometimes fall below the sensitivity of the test,
which is very interesting. It was kind of not quite the way that they should be, but.
Yeah,
right.
no, and Dr. Dr. Austin, really points that out and says that in invasive cancers, sometimes the HPV test is going to be negative, and I like to point out that we're doing cervical cancer screening not to pick up invasive cancers, but to pick up pre-invasive disease. We certainly want to pick up invasive cancers, but we if we do, it's kind of a fail in a way, so that's something to think about as well.
Yes. And I guess it's a good thing because if you only had primary HPV screening, you would totally miss those cases. So correct.
That's exactly what his point is. Yeah. And we see that in HSIL as well. If you just did HPV testing, there's about 5% or so of HSILs that you're going to miss.
Interesting. Yes. Well, thank you so much. I truly appreciate this. This was a great lecture, a very good overview, and thank you for answering all these questions, and thank you for volunteering your time on this.
Thank you, Galiz.
All right, everyone. So see you tomorrow, same time, and let's talk about COVID and what do we do in our laboratories. Have a nice